for the next talk, we have Dr. Ashish Bakshi, another old friend of mine. Ashish and I were the first batch of DM Medical Oncology from Tata Memorial Hospital, and Ashish also continued his tenure in Tata Memorial Hospital a little while longer. He was a faculty there for a fair amount of time. He's done his basic training in MBBS and internal medicine from Nagpur, and then he moved to Mumbai for his super specialty training. After completion of his tenure at Tata Memorial Hospital, he joined the Hiranandani Hospital, Powai, Mumbai. He also practices at Borivali and at Thane. Over to you, Ashish, for another interesting talk. Ashish has always been presenting interesting cases, and his discussion is usually very, very rewarding. Go ahead, Ashish.
So thank you, Chetan. Can I start my screen sharing now? So can all of you see my screen?
Yes, sir.
Yeah. Okay. So thank you, Chetan, for this opportunity. Today, I'm going to talk about some of the endocrine problems that we face in management of cancer. So, sorry for the technical glitch. So, I will be talking on the challenging endocrine problems that we face in patients with cancer. So, there is a complex interplay between patients with cancer and the endocrine system at multiple levels. It is right from shared etiologies between the cancer and the endocrine system, the endocrine therapies that can cause cancer, endocrine treatment of cancer, paraneoplastic syndromes that can happen as manifestations of cancer, and so on. So the primary focus of today's talk will be the complications, endocrine complications that we face while dealing with cancer patients. So a variety of cancer treatments are used for management of cancer, which traditionally include the surgery, chemotherapy, radiotherapy, and hormone therapy. And increasingly now, as with the increased molecular understanding, we are using more and more targeted therapies. And the last kid on the block is immunotherapy. And all of these treatments have, of course, helped us in improving the outcomes of patients, but also have resulted in several new challenging situations which can lead to complications. So we are going to focus on the endocrine aspects of the this part. Now, the spectrum of endocrine problems faced by the medical oncologists are ranging from the entire endocrine system, right from the hypothalamic pituitary axis to the thyroid, parathyroid gland, pancreas, adrenal, and the gonads while dealing with patients with cancer. Now, the spectrum of problems depends on a lot of factors, right from the primary diagnosis, the comorbidity that the patient has, age of the patient, the type of therapy the patient is receiving, dose of therapy, and duration of therapy. So, the one of the most common problem faced is thyroid dysfunction. Hypothyroidism, as I said, is something that is most commonly encountered, and often the symptoms are subtle. So, the symptoms of hypothyroidism may be incorrectly attributed to the primary disease or to the antineoplastic agent. So, however, the bigger problem is that underdiagnosis of thyroid dysfunction can have important consequences. It can adversely affect the patient's quality of life. It can lead to dose reductions of potentially life-saving therapies, and also hypothyroidism can result in altered kinetics and clearance of the medications, so which can lead to undesirable side effects. In some cases, hypothyroidism is also known to be associated with a better response to therapy also. Now, apart from surgery and radiation, which typically cause a direct impact on the thyroid, several other drugs can lead to hypothyroidism. The common ones nowadays that we see are the drugs like interferon alpha, immunotherapy like ipilimumab, pembrolizumab, nivolumab, drugs like alemtuzumab, which can cause immune dysregulation, whereas destructive thyroiditis is noted with drugs like sunitinib and sorafenib, and also the checkpoint inhibitors. Uh, Thyrotoxicosis is also can be seen paradoxically with all these drugs. So the amount of thyroid dysfunction that can happen will vary between patients. Apart from that, some of the drugs can cause abnormal thyroid function tests without actually causing thyroid dysfunction, like low serum thyroxine binding globulin or high serum thyroxine binding globulin can be seen as a result of these drugs. Tyrosine kinase induced hypothyroidism is increasingly seen as a major problem. We have heard Dr. Apar Ganti on talking about the use of TKIs in the management of thyroid cancer. So, as you can see, most of these drugs which are used for the treatment of thyroid cancer, they can lead to a very varying degree of hypothyroidism, depending upon what is the definition used in trials. But it can range from up to 30 to 50% of the patients. Similarly, multi-kinase inhibitors like axitinib, cabozantinib, lenvatinib, regorafenib, which are used for the treatment of renal cell carcinoma, hepatocellular carcinoma, GIST, and so on. In them also, you can see a range of hypothyroidism seen in patients, right from 5 to 20% of the patients. Now, it is important that patients should be closely monitored with free T4 and TSH levels. Those patients who have TSH levels more than 10 or with low free T4 levels, they should be started on levothoraxine. Initially, the starting dose is 1.6 microgram per kg, but those patients who have a coronary artery disease, you can start with a lower dose. Important is to note that in those patients who have a central hypothyroidism, you cannot use TSH for monitoring treatment. So in those patients, free T4 should be used for monitoring. Sometimes you see a immune, as I said, destructive thyroiditis due to the immunotherapy. In some patients with severe hypothyroidism, one may have to add steroids in case if the inflammation is too much. Usually, grade 1 and grade 2 hypothyroidism, you can continue the checkpoint inhibitor therapy. But if the side effects are grade 3 or grade 4, then one may have to stop the immunotherapy in that situation. Another common thyroid is the hormonal dysfunction that we encounter is the hypothalamic pituitary dysfunction. This is often seen as a result of radiation, most oftenly, less commonly due to surgery or chemotherapy. Now, the degree of hypothalamic pituitary dysfunction depends on the dose of radiation given. Doses like 10 to 15 gray, which are used for total body radiation in patients receiving BMT, in them the time to development of growth hormone deficiency is less. But however, those TSH deficiency and ACTH deficiency is less in those patients. But as the dose of radiation increases from 10 to 15 gray to 60 gray, which is often used in patients with brain tumors, the degree of suppression of all the hormones increases. So in those, the higher the dose, you will see all the systems getting affected with the effect of the radiation. Now, another common side effect that is encountered is adrenal dysfunction. As you can see from this graph, there is an increasing incidence of adrenal dysfunction in patients with cancer. This is primarily due to the introduction of monoclonal antibodies and protein kinase inhibitors, which have been introduced in the treatment of cancer. So, host of monoclonal antibodies and protein kinase inhibitors are known to be associated with adrenal insufficiency, and therefore patients should be monitored for this function. A very commonly used drug is magistrol acetate, which we commonly used in patients with cancer as a appetite stimulant or as a hormone therapy. And this drug also has been known to be associated with adrenal insufficiency, which is often overlooked. Similarly, drugs like ketoconazole, drugs like abiraterone, which are commonly used for treatment of cancer, can also lead to primary adrenal insufficiency, and these should be monitored in these patients. Pancreatic dysfunction is again a very common problem that we see increasingly. Elevated HbA1c is known to be associated with aggressive tumors, particularly in colon cancer, prostate cancer, and endometrial cancer. And increased glycemic control is known to be associated with reduced risk of infection and cancer-specific mortality. Now, studies have shown that those patients who have diabetes, their outcomes are inferior as compared to those patients who have no diabetes and cancer. Now, hyperglycemia during chemotherapy occurs in roughly 10 to 30% of patients. The common causes are glucocorticoids and L-asparginase, but increasingly mTOR inhibitors like everolimus and PIK3 inhibitors like the drugs that we use nowadays they are known to be associated with hyperglycemia in 13 to 50% of the patient. Similarly, the PD-1 and PD-L1 inhibitors are not very commonly, but in about less than 1% of the patients can cause autoimmune insulitis and which can lead to secondary diabetes. So patients should be screened for blood sugar while the patients are, say, for example, they are on everolimus or other drugs which can cause hyperglycemia. HbA1c should be monitored, and in patients who are on immunotherapy, they should be you should check for anti-GAD antibodies and anti-isolate cell antibodies. The treatment of hyperglycemia remains standard within the form of either insulin or sulfonylurea. If the diabetes is not coming under control, then in some cases one may have to withdraw the anti-cancer treatment. Metformin is one drug that is used for commonly for treatment of cancer. It has been shown to reduce the incidence of cancer and mortality from cancer. It has also been shown to reduce the likelihood of relapse, and therefore it is being explored currently as an adjunct therapy in several cancers. Recently, one trial unfortunately failed to show any benefit of metformin for cancer prevention. Now, bone health is again commonly affected in patients with cancer. Patients often present with osteopenia or osteoporosis, and which can lead to several complications like fractures, spinal cord compression, hypercalcemia, and so on, which can impact the quality of life and survival of these patients. Particularly, therapy associated bone loss is known in patients with aromatase inhibitors in postmenopausal women, those patients who undergo bone marrow transplant, patients with prostate cancer who are receiving androgen deprivation therapy, and those patients who develop ovarian failure secondary to chemotherapy. So that's where bone mineral density should be closely monitored in patients who are receiving such kind of therapies. And the degree of osteopenia or osteoporosis is directly proportional to the duration of therapy. The longer the duration of therapy, the greater is the likelihood of bone loss. Another challenging problem that is faced in oncology is the late endocrine side effects of cancer treatment, which again can have a range of hypothalamic pituitary manifestations, thyroid manifestations like hypo or hyperthyroidism, metabolic syndrome, obesity, diabetes mellitus, and gonadal failure as a result of the therapy. And in children who are treated since childhood for short stature, growth failure, low bone mineral density, and so on. So, a spectrum of manifestations involving the growth hormone, FSH, LSH, central hypothyroidism, AVP deficiency, similarly, thyroid gland dysfunction, gonadal dysfunction, skeletal damage, all of these are seen, and patients should be periodically monitored for these manifestations throughout the course of their life. Now, briefly, for 5 minutes, I would like to emphasize on immunotherapy related toxicities because this is something of a very evolving topic in the last maybe 5 to 10 years as we are increasingly using more and more immunotherapy. Immunotherapy related toxicity, usually the onsets are very early, maybe within a couple of months of starting immunotherapy. One can see these manifestations. Dysfunctions like thyroid dysfunction, they can be prolonged and probably can remain lifetime. Uh, those patients who have primary adrenal insufficiency, in case if it is severe, then often they require discontinuation of the treatment. The spectrum of manifestation depends on the type of immune checkpoint inhibitor therapy. Patients who are given anti-CTLA4 therapy, often they are more likely to have hypophysitis. As against that, patients treated with anti-PD-1 or PD-L1 inhibitor, they are more likely to develop hypothyroidism. And the side effects are more when the two drugs are combined. Immune checkpoint inhibitor induced hypophysitis can affect adrenal, thyroid, and gonadal function. Most often, as you can see here, three hormones are affected, but ranging from one hormone to five hormones, multiple series of hormones can be affected as a result of hypophysitis. So, monitoring for these hormones should be closely done when the patients are on this therapy. The usually most often the grades of side effects are grade 1, grade 2, grade 3, grade 5 side effects resulting in discontinuation of therapy or resulting in death are very rare, usually less than 1%. Whenever you are giving a combination of PD-1 and CTLA4, the onset of therapies is side effects is earlier, and the duration of side effects is also for a more prolonged period of time. Rates of discontinuation by and large in trials are very, very less. Hardly less than 5% of the patients are actually required to discontinue therapy, and the side effects can be manageable. While giving therapy, patient should be monitored at baseline for thyroid and ACTH and cortisol levels. And typically, during while the patients are on therapy, we monitor these hormones every 4 to 6 weeks. And similarly, for adrenal and pituitary, we monitor every 2 to 3 weeks during therapy. Then a lot of antibodies have been detected in patients who are developing adrenal dysfunction as a result of the immune checkpoint inhibitors. So anti-pituitary antibodies are noted in patients with pituitary dysfunction. 21 hydroxylase antibodies are detected in patients with primary adrenal insufficiency. Those patients who have thyroid dysfunction, in them we can see thyroglobulin antibody or anti-TPO antibodies. So these antibodies can be tested while the patients are on therapy in case if you're suspecting hypothyroidism or other adrenal dysfunction. So while managing the patients, if they are grade 1 or grade 2 side effects, then patient should be continued with therapy by and large. If the side effects are grade 3 or grade 4, then the immunotherapy should be stopped and the patient should be treated appropriately first. Usually, rechallenge can be done in the event that a rechallenge can be done in the event that the immunotherapy side effects has reduced to grade 1 or grade 2. However, one has to permanently discontinue immunotherapy in the event that the treatment-related toxicity does not resolve to grade less than grade 1 within 3 months of the last dose of immunotherapy. So I think with this, I would like to conclude my talk. There is a complex interplay of endocrine system and cancer. Endocrinologists and oncologists should be aware of the spectrum of disorders that we see involving the endocrine system in patients with cancer. Most importantly, for oncologists, timely referral is important. One should keep a high index of suspicion and refer the patients early to endocrinologists so that the side effects can be picked up when they are grade 1, grade 2. And teamwork is essential to mitigate the adverse effects of endocrine dysfunction in patients with cancer. So I think with this, I will conclude my talk. Thank you so much.
Thank you, Ashish. That was an excellent overview, and as usual, you made academically the content was really very rewarding. Uh, are there any questions for Dr. Ashish? Okay, so since we are reaching the end of this session, we were allowed time till 10:30.